been tasked to talk about the future of biomarker-driven advanced non-small cell lung cancer, I believe. You guys have had us talk about EGFR and ALK-driven lung cancers. So today, in a short time, I've been tasked to cover multiple oncogene-addicted lung cancers. I have a lot of slides for which I apologize because there is so much data to go over. And some of the slides I may just go over very quickly, which probably don't require a lot of explanation so that we can cover all the topics. These are my disclosures, nothing different from the last time I spoke. Okay, so I'm gonna discuss the following things in my talk. Just a brief discussion of the landscape of non-small cell lung cancer in 2022. Then I will cover each mutation individually, starting with ROS1 mutations, RET fusions, KRAS mutations, MET exon 14 skipping mutations, NTRK fusions, BRAF mutations, and then summarize. And there are a couple which I've missed, but I think I just don't have the time to go over all of the mutations in 40 minutes. And we hopefully will have some time at the end for questions. For all of my colleagues who are listening, I highly recommend reading this paper recently published in the Journal of Clinical Oncology by my colleague here in Singapore, Dr. Daniel Tan. And it's a nice summary that goes over targeted therapies for lung cancers with oncogenic driver molecular alterations, pretty much encompassing what I'm going to be talking about today. Now, if you look at this pie chart, and I'm sure you've seen this in many presentations and papers as well. But this is interesting because it talks about incidence of oncogenic driver alterations, both in Asian and Western populations, and shows the difference. So the outer circle represents the Asian populations, whereas the inner circle represents the Western population of patients with non-small cell lung cancer. And what is quite obvious as soon as you see is that almost half of all patients with non-small cell lung cancer in Asia have cancers that are driven by the EGFR gene mutation, exon 19 and exon 21. This is in stark contrast to the West population where it's only about 16%. And I believe in the subcontinent in India and Bangladesh and Pakistan is somewhere around 15 to 25%. The other very obvious difference is the presence of KRAS mutation, which is quite common in Western population, about 15%, whereas in Asian populations is only about 2.8%. Most of the other more rarer or uncommon mutations I listed here are relatively equivalent incidence in both populations. But even today with comprehensive genomic profiling, almost 40% of patients in the West don't have recognizable driver mutations, and about 20% in Asia don't have recognizable driver mutations or actionable alterations. So this is a nice summary slide that goes over the timeline of FDA-approved targeted therapies for oncogenic-driven non-small cell lung cancer. Obviously, disclaimer that we may not have all these drugs in our countries as of now, but I'm sure at some point in the near future, we should have access to these drugs for our patients. And you can see from 2011, where we had a very few handful of approved therapies, to 2021, where there are so many new treatments that have been approved. You have already heard experts talk about EGFR mutant-driven lung cancer and the availability of multiple new tyrosine kinase inhibitors, second generation, third generation, and more recently amivantamab for exon 20 insertion. You've heard about ALK mutations, all the way from approval of crizotinib in 2011 to last year approval of lorlatinib in first-line setting. What I'm going to be talking about is all the rest: ROS1, NTRK, RET, BRAF, KRAS, MET, and HER2, which all have been more recently since 2019. So very exciting time for management of non-small cell lung cancer, and many opportunities and options for our patients in terms of targeted therapy. So let's begin by talking about ROS1 rearrangements in lung cancer. So the ROS is a proto-oncogene encoded by a gene located in chromosome 6q22.1. It belongs to the subfamily of tyrosine kinase insulin receptors. Was first identified in 1986 during research involving the chicken sarcoma RNA UR2 tumor virus. The exact physiological role of ROS1 is still controversial. Its expression has been observed mainly in lung tissue, followed by cervix and colon, and it shows a substantial similarity or homology to the ALK protein. And that also explains the benefit of drugs which are similar to drugs used in ALK-driven lung cancers. ROS1, there can be a number of ROS1 fusion partners, and this is just a table going over the common fusion partners. And this alteration in ROS1 that leads to gene fusion results in proteins that are robust oncogenic drivers. And as a result of this fusion proteins, ROS1 kinase activity is constitutively activated, leading to increased proliferation, survival, and migration due to upregulation of the JAK-STAT, MAP, ERK signaling pathways. The most common fusion partner is CD74. Now, the ROS1 rearranged lung cancer was first described in 2007, and it probably accounts for about 1 to 2% of all non-small cell lung cancer patients. Now, this may seem small, but if you look at worldwide, we estimate almost 15,000 new cases of ROS1-driven lung cancer. The phenotype of these patients is quite similar to EGFR and ALK in that they are light smokers or non-smokers, and they tend to be young. Adenocarcinoma is the most common histological subtype, but we also see rarely ROS1-driven cancers that are large cell or squamous histology. As I already mentioned, there's significant overlapping clinical features with ALK rearranged lung cancer. But if you do see a ROS1 mutation, it's exclusive to EGFR and ALK. The other interesting aspect of the ROS1 driven lung cancer, they're exquisitely sensitive to pemetrexed chemotherapy. So they usually do quite well with our traditional platinum pemetrexed doublet chemotherapy. In terms of methods of detecting ROS1, this I had already touched on in my previous talk. So it's a fusion rearrangement. So you can detect it by FISH, IHC, NGS, PCR, or liquid biopsy. All of these methods have their benefits and disadvantages. I think the difficulty with the IHC is that there are a few false positives and you still need confirmation with FISH or NGS. Whereas NGS, which can be done with on both DNA or RNA, while more costly than FISH or IHC, it is highly accurate to detect the ROS1 mutation. I've also been using a lot of liquid biopsy, but has to be used in the right context, usually quite sensitive if there's a heavy tumor burden. FISH is most commonly used in pathology labs across the world. As long as you have good expertise, I think it is quite an accurate test as well. So just briefly going through all the trials that led to approval of agents and benefit of agents in ROS1 positive lung cancer. So the first one was the Profile 1001 trial, now published almost 7 years ago, where we saw that the crizotinib was an active agent leading to a response of 70% and a very high median PFS, 19 months, quite spectacular. And you can see that even with updated data, we are seeing a 4-year survival of 51%. So quite reassuring, showing quite robust activity of this agent in ROS1-driven cancers. More recently, there have been small trials looking at ceritinib in patients with ROS1 positive cancer, both in patients who are treatment naive or have had chemotherapy as first line, and again, consistently high response rate. And in crizotinib naive, PFS similar to crizotinib of 19 months. Lorlatinib, which is also approved in ALK positive lung cancer, has been tested in ROS1 mutation positive lung cancer, again showing high response. And these are patients who had been treated with crizotinib in first line, still having a 47% response rate, and a treatment median duration of treatment of 5 months, and a treatment duration of 7.3 months, a median PFS of 7.6 months. Entrectinib is active in ROS1 positive non-small cell lung cancer. Again, similar to other agents, high response rate, most patients are benefiting. Even those patients who had baseline CNS disease show high response rate with this agent of 74% and a high median PFS. But of course, if you don't have CNS disease, then your PFS is even longer, of almost 26 months, which is really quite remarkable. We know that in ROS1 driven lung cancer, there is a higher incidence of brain metastases, both at baseline or on relapse. Repotrectinib, which was recently tested in both TKI naive and TKI pre-treated ROS1 positive lung cancer, again, high response rates, robust, as well as long duration of response, as you can see in this slide. So now we have so many agents which are active. How do you choose which is the best agent for your patient? As you can see, the PFS in all these agents is similar, very high, approaching 2 years. Lorlatinib and repotrectinib has a very high intracranial response. So these agents may be considered in this subset of patients. Or you can consider the drug based on the side effect profile. Crizotinib can cause visual changes, hallucinations, peripheral edema. Xeritinib has a lot of GI side effects. This was an issue when it was approved for ALK-driven lung cancers. Repotrectinib can sometimes cause dizziness and neuropathy. So these unique toxicities of each drug can also help choosing the right drug for your patient. But unfortunately, none of these treatments are curable. Most patients or cancers will develop resistance. And now we have also elucidated multiple resistant mechanisms to these agents, including activation of bypass pathways such as EGFR and KIT, as well as development of resistant mutations such as 2032R, which is the most common resistant mutation. So in this situation, if you are able to do genomic analysis at the time of progression, if you do find G2032R, drugs such as cabozantinib or repotrectinib, which are active in this mutation, should be chosen. So that's why I feel there is potential for resequencing of tumor or liquid biopsy to detect resistant mechanism, now that we have drugs which we can choose specifically based on the resistance mechanism. So moving forward to RET fusions in non-small cell lung cancer, relatively recent discovery. Again, not common. 1 to 2% of advanced lung cancers are known to have RET fusions, and they can be multiple partners in KIF, 5B, CCD, C6, NCOA4. And the other cancer we frequently find RET fusion mutations are in medullary thyroid cancer. But previously, number of small trials looked at multi-kinase tyrosine kinase inhibitors such as cabozantinib, sunitinib, sorafenib in these individual patients or cancers, and the responses were quite poor, and the efficacy was quite modest. Fortunately, more recently there have been development and introduction of more specific or selective RET inhibitors such as selpercatinib and prasitinib. As you can see, their activity is mainly against the RET fusion, as compared to the multi-kinase inhibitors such as lenvatinib and sunitinib that have more multiple targets that they affect. So the Liberator trial was again a phase 1, phase 2 study of selpercatinib, these hard to pronounce, in RET altered cancers, including RET fusion positive non-small cell lung cancer. So in these small cohort of RET fusion positive lung cancer, even patients who were previously treated with platinum-based chemotherapy, the response rate was 64%. And again, very robust median PFS of 19 months. And in those patients who were completely treatment naive, response rates were 85%, and the median PF was not reached. So this is a very active drug in these patients. And in May 2020, FDA granted accelerated approval for the treatment of adult patients with metastatic RET fusion positive lung cancer. To note, the approval is not line specific, meaning you can use the drug in first line, second line, or later lines. Pralsetinib is the other agent, again tested in a small study showing similar response rates and PFS, and also quite soon after was granted accelerated approval. So you have two agents here. They are new agents in development. These are just two examples, and we'll wait to see what their trial data shows. The other interesting aspect of RET fusion is that they can sometimes be responsible for mediating resistance to osimertinib in our patients with advanced EGFR mutant lung cancer. Again, highlighting the fact that I think doing repeated genomic profiling at the time of progression can be helpful, because if you can elucidate or identify the mechanism of resistance, sometimes these mutations are targetable. So there's just one example published in JCO Precision Oncology last year of a patient who had developed a RET fusion post-afatinib and cetuximab, and this is demonstrating the progression of the lung cancer, and was switched to osimertinib and pralsetinib, which is a RET inhibitor, showing a good response. And here's another case of osimertinib with the other agent, selpercatinib, where in that patient who had progression with the RET fusion post-osimertinib, showing response in the liver after just addition of selpercatinib to osimertinib within a month. So very impressive results indeed. So we finished with ROS1 and RET fusion. Now we switch gears to KRAS G12C, which, as I said, seem to be much more common in the Western population as compared to Asian patients. But interestingly, I have a patient, I should say, who's a 56-year-old Chinese female who presented with on and off cough for a few months in February of 2020. So after a few failed courses of outpatient antibiotics given to her by various GPs, she finally underwent imaging in the form of X-ray and CT thorax at an outside institution. And this showed, unfortunately, a right upper lobe mass and a hilar and mediastinal adenopathy that was very suspicious for malignancy. So you can see this is her baseline CT scan with the ugly looking large right supra lung mass and prominent adenopathy. She also had a solitary 3 mm brain metastases on presentation. And again, this is her PET scan showing an active tumor. So we got the CT-guided biopsy of the right upper lobe lung mass that confirmed adenocarcinoma. She had elevated LDH, which sometimes can denote aggressive disease, and multiple elevated tumor markers on baseline. So this is an interesting case because at the outside institution from where she came to see me, they had a reflex testing protocol for EGFR, ALK, and ROS using single biomarker tests. These were all negative, which was surprising to me because she is Asian, non-smoker. Her tumor was PD-L1 positive. So for the solitary brain met, we started by doing SRS, stereotactic radiosurgery, in February of 2020. That's 2 years ago. And what was left was a T4N1 lung cancer, which we decided to treat with concurrent chemoradiotherapy because it was, at least at that time, we didn't have any actionable alteration in her cancer. So she had a good response to the chemo RT, and then I switched her to maintenance pemetrexed with pembrolizumab because she was PD-L1 positive. And she's done very well. She continues to be in a complete remission 2 years since her diagnosis. In fact, I'm giving her pembrolizumab now every 6 weeks. And fortunately, she's not had any immune-related toxicity so far. Now, why I bring up this case is that even though her reflex testing was negative and I did not have access to her tumor, since the biopsy was done at an outside institution, I decided to send a liquid biopsy in her case using the Foundation One platform, because I wasn't convinced that she didn't have a oncogene addicted cancer, considering she was non-smoker Asian. And this is her actual report, as you can see, dated February 2020. And to my surprise, she had a KRAS G12C mutation. This is one of my first patients where I found this mutation. So again, not the typical phenotype. She's not a smoker. She's not a Caucasian. She's an Asian woman. And interestingly, at that time, there was no drug that had been yet approved for treatment of these patients. Of course, now things are different. So even if even though I had this information back in 2020, I still treated her with chemotherapy and immunotherapy since I had no other approved treatment for her lung cancer type. But of course, things have changed now, which in this case leads into my discussion about KRAS mutations and advanced lung cancer. So as I said, it's actually the most common oncogenic driver in non-small cell lung. If you consider all the patients with non-small cell lung cancer, it's seen in about 25% of non-squamous and about 3% of squamous, but there's significant heterogeneity with specific mutations and co-mutations. KRAS G12C is the most common variant and accounts for almost 40 to 50% of all KRAS mutations in lung cancer, as shown in this pie chart. So CodeBreak 100 was one of the first trials looking at the efficacy of sotorasib, which is a KRAS inhibitor in pre-treated advanced KRAS mutant lung cancer with G12C mutation. So it was a phase 2 trial evaluating 960 milligrams of sotorasib in patients who had already failed 1 to 3 prior standard therapies. Almost 81% of these patients had had platinum and IO therapy. And you can see it was a reasonably active drug with a response rate of 37%, much more than chemotherapy in the third or fourth line, which these patients would have got otherwise if they were still fit enough. So a disease control of 80% with a median duration of response of 11 months. So median PFS of 6.8 months. So exciting agent in this situation. CodeBreak also eventually showed a median overall survival of 12.5 months, which is quite promising. Reasonably well-tolerated drug. Most of the side effects were GI related. So based on this small trial in May 2021, the FDA granted sotorasib accelerated approval for treatment of adult patients locally advanced or metastatic KRAS G12C lung cancer who had received more than prior systemic therapy, more than one line. One line or more than one line. So if and when my patient does progress, this is probably an agent that she would be eligible for. The Crystal trial, on the other hand, looked at another compound called adagrasib in pre-treated patients with advanced KRAS G12C mutation positive lung cancer. And this was also early phase trial and again showed efficacy with high response rate of 45%. So I won't go over these. These are available in my slides if anyone wants. Again, GI side effects seem to predominate. So at least 2 compounds now available for treatment of KRAS G12C non-small cell lung cancer. Now I will switch my attention to a more interesting mutation called the MET exon 14 skipping mutation, also recently discovered. This is just a cartoon to explain how this mutation occurs. So in normal splicing, if you remember, we had discussed this previously, DNA is converted into pre-mRNA when splicing converts that to mRNA. So the introns, which are non-coding regions, are removed, and the exons, which are coding regions, are retained and then eventually transcribed and translated into protein. But in the case of exon 14 splicing mutation, there's an error, and by mistake, the entire exon 14 is spliced out. And this skipping of exon 14 leads to reduction in the MET protein, which acts like an oncogenic driver for the cell. So this is explaining it a bit further. Normally, exon 14 allows degradation of the cell, but if you have a splicing error, there's loss of ubiquitination, and this leads to increased stability and kinase activity of the HGF hepatocyte growth factor, and that leads to proliferation of the cell. So there's been a lot of interest in this uncommon and unusual mutation, and now we have a number of drugs that seem to be effective in this condition. There are three types of drug. The type 1 are the ATP competitors that bind to the ATP binding pocket of the active form. Example of type 1A is crizotinib, type 1B is capmatinib, tepotinib, and savolitinib, which are more interactive, more specific. And then you have the type 2 and the type 3, which I won't discuss today. A very interesting case series published now in 2015 showed that MET exon 14 is a targetable oncogenic driver mutation. Patients who had this alteration and had been previously treated with 2 lines of therapy for advanced lung cancer were given MET inhibitor, showing a good response, as you can see in this liver MET and the primary lung cancer, in this case using crizotinib, and in this case using cabozantinib. So Profile 101, which we have discussed previously, had a small cohort of patients with MET exon 14 mutation, and this showed that crizotinib was effective in this subgroup of patients with a response rate of 32% and a PFS of 7.3 months, which was quite healthy in pre-treated population. But more recently, there have been introduction of more specific MET inhibitors in the form of capmatinib. In a single arm phase 2 trial, multiple cohorts, a patient was selected based on MET exon 14 mutation with measurable lesions and were treated with capmatinib. It was a dose finding study. And I'll just skip this busy tables and basically showed that there was effectiveness. Similarly with tepotinib, the other MET inhibitor, again studied in a single arm multi-cohort phase 2 study with one cohort having MET exon 14 skipping mutations, again showing very good response rate across the board, both on the basis of tissue and liquid biopsy. So you notice one common theme to these drugs, these tyrosine kinase inhibitors. A lot of them have been approved based on small phase 1 or phase 2 studies. And the reason for this is because these are not very common mutations. So hard to design very big trials with a number of patients, because it's hard to recruit patients to these trials. So I think this is the future of precision medicine, where we are identifying these rare actionable mutations and immediately looking at the efficacy based on small trials. Now skipping focus, skipping. Now changing attention to NTRK fusion in lung cancer. So, NTRK genes in normal biology are expressed on neural nerve tissue or neuronal tissue, and they have roles in development of nervous system. They're really rarely expressed in normal non-neuronal or cancerous tissues. So there are 3 receptors for the 3 genes, as mentioned here. And when these NTRK genes undergo mutations and gene fusions, this results in TRK chimeric fusion proteins, which lead to uncontrolled TRK kinase function and cancergenesis. So for NTRK genes, fusions are activating and predictive to response of, and predictive of response to TRK inhibitors. This is important to understand because not all structural rearrangements of NTRK result in productive fusions with chimeric RNA and protein. So it appears in some studies, at least, that testing for chimeric RNA may be the most direct and accurate method to detect oncogenic fusion. So I think it's important when you're choosing your genomic platform that is comprehensive and will pick these fusions up. So NTRK fusions are found across diverse cancer types, both adults and children, including gliomas, thyroid cancers, sarcomas, lung cancer, which is relevant to this talk, pancreatic cancer, colon. So again, multiple cancer types. So I think it behooves us to search for these mutations, even though rare, because at least we have now targetable drugs that can help our patients. But overall, these continue to be very rare. And actually, I haven't seen a single patient yet who has these fusions. But one of my colleagues has a patient with brain cancer who has a fusion and is currently on treatment. So then you could ask me, well, it's so uncommon. When should we test? Should we test everyone upfront? Well, obviously, most importantly, do you have the drug? Because if you don't have the drug available in your area of practice, then it's likely, not any point in testing for this fusion. But if you do have the drug and there's no effective systemic therapy, I definitely think this should be looked out for. The other problem that you may face, that if you do have NTRK fusion positive cancer, after progression, there are now studies even looking at resistant mutations to help guide clinical trial options and new agents. So this field is also moving quite fast. The first generation TRK inhibitors just were approved not even 2 or 3 years ago, and we're already looking at second and third generation. Again, NTRK gene fusions can be detected by NGS, RNA, DNA, or IHC. But NGS is the preferred method because it can look for all the gene fusions. The other option could also be RNA-based NGS. So we already discussed this. So there are 2 drugs which are FDA approved. The first generation TRK inhibitors, larotrectinib and entrectinib, again, very effective drugs. And entrectinib is also approved for ROS1 positive metastatic lung cancer, as we discussed. So this is a tissue agnostic approval. So this is interesting. So it doesn't matter what is the cancer subtype, as long as you have this fusion, the drug is approved. So this is highlighted by this study, which was presented last year at ASCO, again, using larotrectinib. It is efficacious across all tumor types with NTRK fusion, so irrespective of the tissue of origin. Same goes for entrectinib, again, in a paper published in 2020, overall response rate above 50%, multiple tumor types, all with NTRK fusion. So I'll just skip this slide. Now, as I said, that now we are seeing resistance to first generation TRK inhibitors, unfortunately, despite prolonged responses. And this is why we are looking at mechanism of resistance, including off-target or bypass mutation and on-target or kinase domain mutations. And there are new compounds already in development, as listed here. They don't have names yet in these patients. Off-target resistant mechanisms have also been identified in KRAS, MET, BRAF, for which we already have some drugs or chemotherapy or clinical trials. So these are just an example of some ongoing studies with the new agents. So then moving to BRAF mutations. So BRAF V600, again, first identified in melanoma, then subsequently in lung cancer, and now in colon cancer as well. 2% of all mutations in lung cancer usually associated with poor outcomes with platinum-based therapy alone. They're seen about half and half in smokers and non-smokers. The first study looking at the combination of a BRAF inhibitor, dabrafenib, and a MEK inhibitor, trametinib, in non-small cell lung cancer was published in now 6 years ago almost by Dr. Blanchard from France. This was a phase 1 phase 2 single arm dose finding study. And if in stage 1, Drabafenib and Trametinib was given at these doses, and there were more than 6 responses, the study progressed to stage 2. So not a lot of patients, there were only 33 patients who were evaluated. 36% of these were male. As I said, smoking history was about 50-50, 27% of never smokers, 40% less than 30 pack years, and 30% more than 30 pack years. Most had had at least one line of treatment. About 30% had had more than one line. And again, very impressive data with this combination. Most patients responded with good treatment duration of response. But this was a toxic combination with 45% having grade 3As. Interestingly, this unique side effect of MET inhibitor, which is fever, pyrexia, and 18%. So pyrexia, diarrhea, and GI side effects were the main side effects, and there was one death due to pleural effusion and disease progression. So it was an active regimen in small cohort of pre-treated patients with some toxicity but manageable. And this combination was subsequently approved. There's another case of mine that I have been treating since 2017. And in the initial NGS test on a tumor, I found 2 interesting findings. One was BRAF V600E mutation, and this was a non-smoker, as well as a high TMB of 29 mutations. And at this time, 2017, the TMB data as it related to the predictive efficacy to immunotherapy was just being published. So it was somewhat of a dilemma in my case if I should treat this patient with the BRAF inhibitor, although the combination at that time was not approved, but we did have a BRAF inhibitor, or if we should treat her with immunotherapy based on the preliminary data that was available. So I had actually discussed this case at the Molecular Tumor Board at Johns Hopkins, and they recommended BRAF inhibitors. But I decided to go against that recommendation, and I treated her with chemotherapy and pembrolizumab. And as you can see, January, this is her baseline scan, a large tumor in the lung, liver mets, so aggressive disease, and she also had brain mets. But within a couple of cycles of chemotherapy and pembrolizumab, she had a very good response. Here's her liver met in January, almost completely disappearing after 3 cycles. These are the lymph nodes in the mediastinum. The lung primary, again, very good response. And as of early this year, she's still in complete remission. She's had 2 years of pembrolizumab, and I finally told her to stop because she was in remission, and so far she has not had a relapse, showing that she is exquisitely sensitive to immunotherapy based on the high tumor mutational burden. But in her case, I think whenever she progresses, which she will, I probably will challenge her with immunotherapy again. But if she progresses on that, I do have the option of a BRAF and MEK inhibitor in salvage. So sorry, a lot of information compressed to a very short time because that was my task. To summarize my talk, the discovery of actionable oncogenic driver alterations has really transformed management and treatment outcomes for many of our patients, some of which I have shared with you today. Molecular profiling may be considered after failure of first-line treatment in those patients without oncogenic drivers, meaning not every patient needs to get NGS tested initially, although I would recommend, at least in my practice, I do it in the first line. One, because you have a tissue, since everyone needs a biopsy to make the diagnosis. And later on, when the patient progresses, biopsy may not be easy. Liquid biopsy can still be considered in that situation, but again, we have to be careful because sometimes there can be a false negative. There's not a lot of tumor burden because there may not be enough DNA being shed by the cancer. So new targeted therapies, which we have gone over over the past half an hour or so can be considered in later line since they are line agnostic approval. So they seem to be effective even after failure of chemotherapy. Sequencing remains unanswered question. Studies are still ongoing if these targeted therapy should be moved to first line or patients should be given chemotherapy followed by targeted therapy. The toxicities also differ. So just because they are tablets doesn't necessarily mean that they are not toxic. One example is the BRAF and MEK inhibitor combination. Access and cost is a major issue. Even in Singapore, we don't have access to all these drugs yet because these mutations are so infrequent. But I'm hopeful that as we find these mutations, more different types of cancers, that these drugs will become more accessible and less expensive. The other thing we are already seeing, especially in EGFR mutation-driven cancer, that we are using these drugs early on. We are using them in the adjuvant adjuvant setting, and that may change the natural history of these cancers. It may help us understand the resistance mechanisms better. So quite an exciting time in treatment of oncogene-driven advanced non-small cell lung cancer. So I think I will stop here. And again, sorry for the exhaustive number of slides, but I had to cover a number of topics. And thank you. I'll be happy to take questions.
Thank you very much, Dr. Chopra, for a brilliant presentation. Today is your second presentation, and it's wonderful to hear from you. Thank you very much again.
Thank you.
And with us, we have so many participants today. Few of them are very busy and senior consultant oncologist of Bangladesh.
I can imagine this.
But I like to have few opinion or few comments from our eminent professor, Mohammad Abdul Hai sir. He's our patron of our society, and he is the senior most. So, Professor Hai sir, if you are here, we'd like to have some word from you.
Thank you, Dr. Novena. Thanks to Akhil Chopra also. He has given a nice talk today. And as he already gave us talk in last time also. Thank you all very much. It was very elaborate. Unfortunately, we shall never be able to do this in Bangladesh at the present moment. However, we are thankful to Dr. Chopra for inviting us. Thank you all very much. Over to you.
Thank you, Professor.
Thank you, sir. We have a few questions in the chat post. First, I'd like to read some of them. Dr. Ronnie asked that after relapse or progress with the EGFR mutation, based like a treatment with the TKI, should we use ALK or ROS-based TKI?
If report permits.
Sorry, could you repeat that?
After relapse or progression with EGFR-based TKI, should we use ALK or ROS1-based TKI? If report permits.
If further report permits.
If they further doing the biopsy, a report permits, if there's a mutation, we should go for that?
Understood. Yeah, so this is a good question, but I have to say I haven't seen ALK and ROS being a resistant mechanism in patients who have EGFR-driven lung cancer and who have progressed on first, second, or third generation TKI. I personally haven't seen that because these are, as I mentioned, are usually mutually exclusive. But I suppose, you know, if you do see it and you're confident that it's a driver mutation, then yes, I would treat it by a TKI against that mutation.
Yeah, I think there's the answer from Dr. Chopra. And another question from Arman Reza Chaudhary. He is working in the Evercare Hospital. So he asks that if all molecules against ALK is available, which one we should choose and why?
So today, specifically, I was told not to talk about EGFR and ALK, but nevertheless, it's a good question. So we are lucky now we have so many ALK inhibitors. So this becomes a difficult question, which is the best drug to to take. So let's go over some of the, and I'm sorry, I'm not sure what are the drugs available in Bangladesh, but at least in Singapore, we now have crizotinib, which is the oldest. We have ceritinib, we have alectinib, we have lorlatinib, we have brigatinib. I think we pretty much
all
have
are available
all
in our country also.
Okay, perfect. So let's assume you have all available. So I definitely I would not recommend using crizotinib because in head-to-head comparison trials, it's shown to be inferior to both alectinib, brigatinib, as well as lorlatinib. So personally, my drug of choice, first line is alectinib. The approval dose is 600 BD. But I would caution you to be careful because I feel that dose may be a bit high in some patients. It leads to a lot of myalgias and GI side effects. There was a Japanese trial, I think called J-ALEX, which looked at 300 BD, half of that dose, and showed a reasonably good PFS and response rate. So I have been using 300 BD and I've got good results with very long duration of control. After progression on alectinib, we have data with lorlatinib. So that's usually my second line. The lorlatinib, as you know, is also approved in first line, but I prefer to use alectinib because in case patient has progression, at least I have availability of lorlatinib, which is active in most forms of resistant mutations for ALK-positive lung cancer. Ceritinib, I don't use anymore because it was compared with chemotherapy and showed to be superior, but not compared to alectinib or one of the new drugs. Yeah, so I mean that's what I usually use. Alectinib is my drug of choice right now.
Thank you. So next question also from the Arman Reza. What is the sequence? That is, I think you have already.
Yeah, so for me at this time, alectinib followed by lorlatinib is the sequence. There's also data of brigatinib effective in the second line. The good thing about all these agents is a very good CNS efficacy. In fact, I had, just to share with my colleagues, I had a young patient I have been treating since 2014. So now it's 2022, 8 years. Started with crizotinib. He was on it for almost 2 years. Then had brain mets, so we did gamma knife. Had switched to alectinib. Switched to brigatinib because we had a compassionate access program. He progressed on that again in the CNS, no progression elsewhere. Again, we did radiation, gamma knife. Progressed, but this time the CNS met was quite large, one of them, so we had to do emergency surgery. He recovered, and then I put him on alectinib. He was on alectinib for almost a year and a half, progressed again in the brain, no progression elsewhere, and now he's on lorlatinib since past 1 year and still in remission. Very effective drugs, but they are toxic if you give them for long duration of time. So he's had some toxicity, but still doing.
Sir, one question regarding your brigatinib use. After brigatinib, what is the consequence of use of or utility of use of alectinib? Because after brigatinib, is there any study that proves that further?
No.
So it's your own choice.
Sorry?
It's your own choice.
No, in this example I gave, we had compassionate access to brigatinib. So in fact, that was what we used because lorlatinib was not available at that time. So it wasn't really all the data-driven decision. It's just that we didn't have all the drugs. Today, if I had to see a patient, I have 2 patients now in my practice. Both are on alectinib, both on 300 BD. They're doing quite well. And if they progress, I will check for resistant mechanism and most likely use lorlatinib because it seems to be active against most mutations.
I have one question. Can I read it from my chat?
Please.
You are showing that when you use the TKIs and doing PET scan after 4 weeks. So what is the minimum time to see the progression or regression for the follow-up cases by using the TKIs?
Yeah, that's a great question. So and patients ask us all the time, how are we going to monitor their disease? So, and this may be too simple an answer, but what I always tell my patient, look at three things: how they feel, right? So their symptoms, the clinical response, cancer markers. So if they have elevated cancer markers, but there also you have to be careful because markers such as CEA have longer half-lives. They take about 3 to 4 weeks before they start coming down. And then scans, imaging. So imaging can be in the form of just a simple chest X-ray or a CT scan or a PET CT scan. So it really depends on the situation. I just saw a lady 2 weeks ago, in her early 30s with a EGFR exon 21 driven lung cancer, but extensive burden of disease. It's been a while since I've seen so much cancer in one individual. And I think the reason, she didn't succumb to the cancer because she's young. So she had brain mets, lymph node mets, bone mets, liver mets, obviously multiple lung mets, adrenal mets. And so in that case, she was in pain, she was losing weight, CA was high. I started the drug. Within a week, she started feeling better, pain got less, appetite got better. So in that situation, I don't need to do a scan because I know clinically she's responding so well. But to answer your question in a more simplistic way, in my practice, I do not repeat imaging for at least 6 weeks. I at least give the medicine, whether it's chemo or TKI, for 6 weeks. And the latest I do is 2 months. When I was in the US, we used to do 3 months, but I find that's too long a duration. But if the first scan is positive, meaning there's response, the second one I may extend by 3 to 4 months. I don't do it at a closed interval. I hope I answered your question.
Yeah, thank you very much. So we move on to the next question. Is from the Ariful Haq, Dr. Ariful Haq. He said, you say sometimes ROS mutation is found in small cell carcinoma, right? So can the same anti-ROS1 antigen for
ROS1 treatment, yes. So there's irrespective of histology, and I would still give ROS1 treatment, yes.
Okay. I think that was all. If someone is like to ask any question, you're free to ask.
There's another question which says, after being treated with EGFR TKI, if there's progression and no T790 mutation, what is the choice of treatment? So again, that's a great question, very controversial. So what are your options? Your options are chemotherapy or chemotherapy plus immunotherapy based on the Empower 150. But the Empower 150 use carbo, paclitaxel, bevacizumab, and etolizumab. And this was the EGFR cohort was quite small. If you read the details of the trial, so at least in the small cohort, it seemed to be effective. But I think there are a lot of ongoing trials looking at this question. We'll have the answer soon. So in my practice, I offer just chemotherapy usually, or sometimes chemotherapy with anti-VEGF such as bevacizumab.
Thank you very much, Dr. Chopra, for all the question answers, and hope the participant is benefit from the following discussion. If someone want to ask any question, you're free to ask. We can have 2 or 3 more questions.
There's another. I just saw a question from Professor Kamal. What is the experience of co-occurring genomic alterations in non-small cell lung cancer? So I have to say, in my own experience, they're quite uncommon. Most of these driver mutations are mutually exclusive. So meaning it's rare to find an ALK, and a ROS together, or an ALK and an EGFR together. It almost never happens. But we are seeing post-progression acquisition of driver, a targetable or actionable mutations as a mechanism of resistance. One example we discussed was a MET exon 14 skipping mutation in someone who had been treated with osimertinib. So I think upon diagnosis, not common, but yes, upon progression, it can be a mechanism of resistance. And that is why I think for at least the oncogene-driven cancers, it is probably worthwhile to do frequent genomic profiling at the time of progression. And you can either do that with a repeat biopsy or you can do it with liquid biopsy. It's expensive, but I'm hopeful that, the cost of these tests are going to come down. They already have come down substantially in the last 5 years. And I think it's going to become a part of standard of care to be checking for these resistant mechanisms.
Thank you.
So the next question is there a simple way to decide either to start with chemo or TKI in advanced carcinoma of lung? Yeah. So, a lot of this depends on your own local infrastructure. When I started practicing in Singapore 12 years ago, the only way to check for EGFR was Sanger sequencing. I used to take about 3 weeks to get the result. And, patients can't wait 3 weeks if they have very symptomatic from a heavy burden of lung cancer. So it's never wrong to start with chemotherapy because chemotherapy works in all types of lung cancer. If the patient is fit enough for chemotherapy, lung cancer is diagnosed, I would start with platinum-based chemotherapy. And then based on what kind of molecular profiling you have available to you, that should be sent concurrently before starting the chemotherapy. And once you get the result, you can always change the treatment. So even today in Singapore, we have droplet digital PCR-based liquid biopsy for EGFR that we can get in 1 day, maybe 2 days. And since 50% of our lung cancers, lung adenocarcinoma EGFR-driven, it's cost-effective to send for this single biomarker-based test. It has a sensitivity of 95%, not 100%. In my previous talk, I had shared an example where the initial test was negative. But most of the time, if you detect it within 2 days, then you can start with TKI. In those patients where the EGFR TKI is and this PCR is negative, I start chemotherapy and I concurrently send a NGS test, comprehensive NGS test, whether liquid biopsy or a tumor biopsy. And when the result comes, I change the treatment. So if I find EGFR, I'll change to EGFR. So there's no study that says it's wrong to start with chemotherapy and then switch. There's no study that says that. The only area where I would be cautious is adding immunotherapy to the first cycle. The reason for that is that now we have data showing that if you use osimertinib post immunotherapy, there is slightly higher risk of pneumonitis. And this is real. One of my colleagues has had a couple of patients who have suffered pneumonitis. So I don't start with chemo plus immuno. I'll start with chemo, wait for the NGS result to come. If no targetable mutation, no actionable mutation, I add immunotherapy to the second cycle and continue chemo-immuno, which is the standard. If you find a targetable mutation, I stop the chemo and I start the TKI. That's at least what I do.
Thank you, Dr. Chopra. Yes, presently actually what?
Yes, I can hear you. Yes, sir.
Yes, sir. Professor Kamajuman Choudhury, sir.
Yeah. Dr. Chopra has given the ideas what he was doing in the 12 years, 10 years ago in Singapore. We are also doing the same thing. We are when the patient are diagnosed with the non-small cell lung cancer, we are in the core biopsy, especially for the EGF, the NGS, or in the foundation medicine. But it takes near about 3 weeks. In the meantime, definitely patient doesn't want to wait for that. And we go for especially chemotherapy. Then when the report comes, we actually are switching over to the same practice is going on in Bangladesh till the current situations here, especially.
Excellent. And I think that's probably the best way to approach it.
Yes, sir. That's the way. We are also working that way. There is a nice comment from Sweden, Karin Habiscon. So he thank you for giving a very nice and clear, comprehensive summary of the lung cancer field.
Thank you.
Yeah.